Hello, this is Dr. Neil Baum from New Orleans, and I'd like to take about 7 or 8 minutes to share with you the concept of outcomes measurement and how we are going to shift gears from volume of patients seen to the value that we offer our patients. We are going to be moving in a new paradigm. And in the past, it was fee for service, and it was the more patients we saw and the more tests we ordered and the more procedures we did, the greater was our productivity and our income. Now we will be rewarding value, and the value is what is important to the patient. And that will be the new method of reimbursement in the very near future. The objectives of this video is to tell you why outcomes measurement is important and discuss some concepts of developing outcomes for various urologic procedures. Healthcare is very expensive. The healthcare budget's over $3 trillion. It occupies 18% of the gross domestic product, but it's of interest that it is not physician fees that represent the majority of the healthcare budget. This is one of my favorite slides that shows a comparison of salaries of a UPS truck driver versus a doctor. If you look at the income of a UPS truck driver after high school, which is shown on the brown on the graph, you can see steady escalation in growth of income if he was working full time. If you look at a physician's income after high school, you see that it decreases because of increasing debt. And a physician doesn't earn as much as a UPS truck driver until he has worked 17 years after high school. However, if you look at the income of a UPS truck driver working the hours like a physician, 60, 80 hours a week, you will see that it takes a physician 27 years to make as much as a UPS truck driver. Point I want to make, and I hope you will consider sharing this with others, is that it is not doctors' fees or doctors' income that is producing the bloated healthcare budget. The definition of value is outcomes divided by cost, but the new definition is going to be value. That's outcomes that matter to the patient divided by the cost. Yesterday, the outcome measurement was morbidity, mortality, length of stay, what was the readmission rate, and what were the lab results such as PSA after surgery. The new paradigm is we're going to be measuring what is important to patients, and we're going to be looking at patient satisfaction, because patients with a positive experience with a physician have better clinical outcomes. The challenge will be that we have to measure apples with apples, and we can't use outcome measurements when some patients have more comorbid conditions. So we're going to have to adjust the risk associated with the comorbid conditions in order to compare apples to apples. To get started, I suggest you take conditions that are well defined and are frequently used and have quantifiable measures, such as cancer surgery for prostate disease, BPH, urinary incontinence, ureteral stones, erectile dysfunction, and even infertility. We've got to look at the metric from the patient's point of view. Examples include, how long did it take the patient to make an appointment? How long did the patient wait in the reception area or the exam room before they were seen by the physician? Did the doctor answer all of the patient's questions? Did someone in the office follow up on any test results and imaging studies within a reasonable period of time? Now, how are outcome measures developed? Usually it is with the use of guidelines. The AUA does have guidelines, and there's an app available for it on mobile devices. So, for example, outcomes after radical prostatectomy, the first two are what's important to the urologist. The last five are what is important to the patient. And now we have to start looking at outcomes that are important to the patient. And we have to adjust for risk, including comorbid conditions such as diabetes, chronic renal failure, the cardiac status of the patient, whether the patient was anemic, whether the patient has chronic obstructive pulmonary disease, what was the patient's BMI, and even psychological factors such as depression. It is shown and documented that patient satisfaction improves quality, it improves patient compliance, and when there is improvement in compliance and quality, we have better outcomes. The current status of outcome measurement is that it is rare and very reactive. At the moment, it is mostly done by hospitals and large practices. Currently in the United States, we have mandated for outcomes management for transplantation, for IVF, and dialysis. So what are the conclusions? The goal is that outcome measurement will result in improvement and reduce variation of care. Outcome measurement is practical with the methodology and the technology that we have available in almost any practice. Outcome measurements identifies major variations in care. The second conclusion is that outcome measurements promotes innovation in the delivery of healthcare, and that is, it is proactive and not waiting for a problem to happen, but identifying potential problems and solving them. And the third conclusion or summary is that we should start with outcomes for common urologic conditions, and we should shift from short-term cost reduction to long-term value improvement from the patient's point of view. Bottom line is there is a benefit to outcomes management to stimulate improvement by focusing on the patient. Final take-home message, the purpose of outcomes management is to improve care and not to point a finger and not to keep score. Hope you found this presentation helpful and useful. If you have any comments or are conducting outcomes management and would like to share them with me, perhaps on another video, please let me hear from you at the email address shown on the last slide. Thank you.